checkpoint inhibitors have proven effective in 10 or 12 different cancers and have FDA approval. And the place that they've been looking most promising in breast cancer is in triple negative breast cancer. We've had some preliminary data, just phase 2 type data in the metastatic triple negative population. And we're getting some intriguing results that in the first line setting, we'd be having response rates in unselected patients of 20 to 26%. In the later line, once women had been treated with multiple lines of chemotherapy, we really weren't seeing any appreciable benefit. But then the really exciting data came when pembrolizumab was utilized in the preoperative setting along with chemotherapy in triple negative breast cancer patients, and it really led to an improvement in the pathologic complete response rate. So that was our real most important signal that if you utilize the checkpoint inhibitors earlier in the course of triple negative breast cancer, that you could potentially have a very big impact. A very important area of research is aimed at taking triple negative breast cancer in the metastatic setting that is PD-L1 negative or is the kind of cancer that's been pre-treated, for example, and trying to change that cancer so that it becomes more susceptible to killing by immunotherapies. There are various strategies that people are looking at to do that. For example, one clinical trial that's going on right now combines the HDAC inhibitor entinostat with atezolizumab. And atezolizumab is a checkpoint inhibitor. In pre-treated patients, it'll help a very small minority of patients. It might be effective in unselected patients, regardless of PD-L1 status, and about 26% of first-line patients by itself. And so by utilizing an HDAC inhibitor, which can increase neoantigens and can increase DNA repair deficiency, you may be able to make that cancer now more amenable to killing by immune checkpoint inhibitor. So this is a big area of research, and the HDAC inhibitors are one example, but there are several strategies along this line. Combining checkpoint inhibitors with chemotherapy is really yielding better effectiveness for patients in other cancers compared to checkpoint inhibitor therapy alone. And so in that vein, that has certainly been evaluated in metastatic triple negative patients. And when the nab-paclitaxel was put together with atezolizumab first in this kind of a safety pilot early phase 2 experience, the response rates were really quite excellent. You know, they were approaching 50% in the first line setting, which would be much higher than you would expect with nab-paclitaxel alone. So that looked quite interesting. And combining chemotherapy such as nab-paclitaxel may change the microenvironment of the breast cancer. There's some evidence that it could decrease T regulatory cells, for example. There may also be some DNA effects of various cytotoxic agents to increase the STING pathway, for example, which the cancer cell thinks it's under viral attack and upregulates PD-L1 and causes the tumor-infiltrating lymphocytes to come into the cancer, etc. So chemotherapy can have some very interesting microenvironment or DNA damaging effects that we don't even necessarily fully understand, but can then prime the cancer, if you will, for eradication by immune checkpoint inhibitors.